When I see somebody with SI joint dysfunction, I typically look at the way they sit, first of all. Because if they're in my office and I walk in and they're kind of listing to the side, they don't want to put all their weight on their ischial tuberosity. That's one sign already that they don't want to have that push-up effect on their SI joint. But then you can also tell by their gait, they will have a little bit of a limp to their gait. And then when you examine them, there's several different physical findings we go by. One is called Fortin's finger sign, which is compression of a bone called the posterior superior spine. And that is a very telltale starting point. But then we also do a test where we actually stress the SI joint through something called a Faber test, which is flexion, abduction, and external rotation, where you turn the hip out and add a compressive force. And there's other SI joint procedures where you lay on the side and you add compression. And all of these kind of go into a figure of maybe this is where the pain is coming from, because there's so many different things that can mimic SI joint pain. So a lot of times we use our findings on exam coupled with their story they come in with, and then we go to the OR and do an injection in their joint for a diagnostic block.